Sir, it has started, sir.
Okay, good evening, friends. Welcome to the 101st webinar of the PG Track program of Delhi CSI. I again welcome you back after quite a long break. There were reasons for this. There were conferences, and we thought that we should stop for a little while. But many requests were pouring in from all of our fellows and residents. So we have again started and reinitiated this unique program. Before we start today's webinar, I have a few comments to make, because this program is specifically for you. I request you to please personally message us, write to us that what kind of topics and lectures you would like to hear. If there are any particular topics or any particular thing that you would like us to cover in these sessions, we would be very happy to do them. We would also love to make these as much interactive as possible. So any questions and suggestions from your side till the time we come to clinical presentation, please type them in the chat box. They will come to us. All these sessions will be available on the YouTube as a recording. You can download them, you can listen to them, you can actually just enjoy these sessions as much as you want. I also have a request to make, which I'll be again making at the end, that allow all the new DM and DNB residents to join in the group. We have already 8-9 groups which are running for this academic program. I request you to write to me in case you don't have the link to join that WhatsApp group, so that you are updated with all the links of the lectures and also the upcoming program. So I welcome you again. And again, we have the privilege and honor of having respected Dr. Sudhay Kumar, sir. Great teacher, phenomenal teacher. And the way he approaches clinics is just a treat to listen. And no one could have done justice to the 101st webinar beginning then. So I welcome you, sir. I also welcome my colleague, Dr. Girish, Professor of Cardiology from JVP Hospital, and Dr. Nitish Nayak, who's the convener and the secretary of the Delhi CSI, and all the members of Delhi CSI and our president also. So I request Dr. Sudhay sir to please take today's lectures on Pulse and JVP in health and disease. Are very relevant, something that you just can't miss in exam. Over to you, sir.
Okay. Thank you so much, Professor Mohit, and the whole team for giving me the chance to interact with you all. Your presence, your contribution, and your say friendly, jolly attitude is an encouraging one for us as well as for the students. The thing, now I have got relief from the Travancore Medical College. So now I am not a faculty there. I am working in a private hospital here. So you can just put me as the cardiologist or former professor of cardiology. Okay, fine. Shall I proceed?
Yes, sir, please. Please, okay. Yes, sir.
Now, why I have chosen this topic? Now, there are different aspects of current cardiology practice. Now, what we learn over 3 years. To become an interventional cardiologist, I think we don't need 3 years. But cardiologist or cardiology training means a clear concept, knowledge about the cardiovascular physiology, the pathology, the clinical aspects, all those things. And it is in contrast to what we are practicing. For example, you talk about the guidelines, class 1, class 2A, class 2B, and class 3. Certain areas you go by the recommendation, certain areas you say that it is my personal experience. That is what is happening. Then the second thing is, as a doctor, what is the relevance of this thing? It may not be that relevant because now people seldom spend time on Pulse and JVP. JVP, it's a Herculean task and they can get diagnosis by other industries. But as a cardiologist, we should know what is Pulse, what is JVP, what is the concept about these things. Now, what are the informations you get? Don't forget, we get a lot of information from regarding the rhythm, cardiac arrhythmias. Because many times, white QRS tachycardia, we debate at bedside to see whether it is SVT, VT, we send to the electrophysiology. But if you have a fortune to see the patient during the tachycardia, just look at the pulse volume, rate, is it regular or irregular? And volume. For example, a regular pulse with varying volume, it's a AV dissociation. An irregular pulse, it is atrial fibrillation. And when there is a problem, you look at the JVP. A wave may not be easy when there is a tachyarrhythmia, but in a bradyarrhythmia, it is not that difficult. can look for Cannon waves, which is regular or irregular. So its a major contribution to diagnosis of complex arrhythmias is available from or is from the pulse and JVP. You get a lot of information on the hemodynamics, cardiac output, vascular resistance, ventricular function. So the pulse and JVP gives a lot of information on diagnosis. It's useful in the therapeutic approach. For example, cardiac failure evaluation, JVP gives a lot of information whether the patient is responding to or not. I may not be bothered about the BNP because it is very expensive. IVC, okay, you won't get how much information you are likely to get to see whether the venous pressure is coming down. You have only borderline, say if it is more than 20 millimeters, it is grossly elevated, that's all. But whether the patient is responding, how much it is coming down, you can get an idea by looking at the JVP. Similarly, looking at the pulse, the rate, the volume, the character, everything contributes to the diagnosis, assessing the response to treatments, and prognostic information also. So we get a lot of information which geriatric cardiologists like us will go for that. There's one thing I think I put because all the postgraduates should go through this thing and analyze it properly. Only then you can understand this. So I think my humble request to all the postgraduates is go through this picture. There you have the electrocardiogram, the jugular vein, the heart sounds, the atrial pressures, the right ventricular pressure, the left ventricular red pressure in red, and aortic. So the timing of these things, for example, the fourth sound occurs after the P wave. It is occurring after the P wave, but before the opening of the aortic valve. Here it is very difficult to assess this clinically. So you get a lot of information. If you go by these things, if you can understand the whole concept of this thing, that means you have studied, you have learned cardiovascular physiology or the hemodynamics of a normal person, the timing of the events, what is the A2A syndrome, where is S3 occurring, all these things. It will take for the PGs who have not gone through that, we have to go through that again and again at least 20 times. Then only you will be able to comprehend it properly. Now coming to the pulse, you know what is aorta, what is happening. During ventricular systole, the rapid ejection of blood at a high velocity or dP by dt, that is the rate of pressure rise in the ventricle, distance the aorta. And in the aorta, the kinetic energy generated by the LV is converted to potential energy, which is stored in the aortic wall. So the kinetic energy generated by the LV pushes the blood forward through the aorta in systole. And in the aorta, this kinetic energy is converted to potential energy, which is stored and it is released during diastole as kinetic energy, which propels the blood to periphery in diastole. So you know that you take the blood flow in the arterial system, you puncture the artery, you find that there is a systolic and a diastolic continuous flow. The systolic flow is generated by the ventricular systole, and that energy which is generated, kinetic energy, is stored in the aortic wall as potential energy. And once the systole is over, this potential energy is released as kinetic energy, which propels the blood to periphery. This is very important because somebody will ask you how the blood is flowing fast in diastole, because there is nothing to push it. Because once my son asked me how the blood is flowing from the pulmonary artery in diastole. Now, it was a difficult answer for me at that time, but what I said was, in diastole, the ventricle is relaxing, the mitral valve is opening, so that is receiving the blood. That's one factor as far as the flow from the pulmonary artery, pulmonary vein to the left atrium is concerned. But the second thing is, this is the energy concept. Now, regarding the pulse, this is an important thing. That is, this is regarding the pulse wave. That is, during systole, a pulse wave is generated, and aorta and the vessels, especially the distal vessel, distant. And these are smooth vessel containing vessels. And once it is distended, it automatically recoils. When it automatically recoils, it produces another pressure rise in the lateral part of systole, that is in green. So this is the forward systolic, and this is the recoilant force, which produces a late systolic pressure. And both this contribute to the classical arterial pulse, which has a hump in the ascending limb, which is anacrotic shoulder. Seldom we pick it up. So the first part is the systolic wave, and this is the augmented diastolic wave. So what we get is the systolic peak systolic or early systolic pressure plus the late systolic pressure, which is augmenting that. That is the augmentation pressure. So total systolic pressure is the early systolic pressure plus the augmented pressure. That is the peak systolic pressure. So what you get is the augmentation pressure is from, let us say this is 100, this is 120, this is 100, this is 20. So you get this 20 as the augmentation pressure. And augmentation pressure divided by the systolic pressure or the pulse pressure is the augmentation index. Okay, that is the augmentation index. Central augmentation index is the systolic augmentation pressure, that is this pressure divided by the pulse pressure. That is the augmentation index. The peripheral augmentation index is the late systolic pressure divided by the early systolic pressure. The late systolic pressure is from here to here. That is the total systolic pressure. That is divided, sorry, there is the total systolic pressure. That is the this 120 divided by the early systolic 100 is the peripheral augmentation index. Now, what is the importance of this is we don't apply it clinically, but this is useful in assessing factors related to atherosclerosis, vascular resistance, and prognostication in atherosclerotic vascular disease. That is more of academic. Now we come back to pulse. What determines the pulse volume? It is one rate of pressure rise. That is, with what speed the ventricle is generating pressure and transmitted to the aorta in the absence of aortic stenosis. So it is the rate of pressure rise in the aorta which determines the volume, number one. Because the volume has two components, actual height plus the way it rises, and obviously the pulse pressure. This is the basic thing, that is stroke volume is predominantly determined by the systolic blood pressure. Sorry, systolic blood pressure is predominantly determined by the stroke volume, and the diastolic blood pressure is mainly determined by the SVR. But these are interrelated to a great extent. But this is a simple approach. That is, systolic blood pressure is determined mainly by the stroke volume, obviously, but it is determined by other factors also. Now, normal pulse, that is normal height, normal upstroke, normal rate of rise, it indicates normal stroke volume, normal systemic vascular resistance. So these two factors, stroke volume is determined by so many factors that we know. And physiologically, a normal pulse indicates that the stroke volume is normal. Not the cardiac output. The cardiac output is over a minute and SVR is normal. Whereas a low volume, a small weak pulse with a normal rise, small pulse, low volume pulse, but a character, upstroke is normal. Upstroke is normal means it will not be absolutely normal. It indicates a low stroke volume, high systemic vascular resistance, and a low dP by dt. The rate of pressure rise is low. That mainly determines the upstroke. So this can be assessed only by the graphic record. You will not be able to appreciate this slow rise if there is no obstruction. The slow rise can be clinically appreciated only if there is a fixed valvular aortic stenosis. This slow rise due to a slow dP by dt, that is, the ventricle is generating pressure very slowly, so that the aortic pressure is rising slowly, the pulse pressure is narrow. That will not be appreciated clinically. You will appreciate this as a low volume pulse. If you appreciate a low volume pulse and you can clinically by palpation appreciate the slow rise, it is severe aortic stenosis. Large bounding pulse, high stroke volume should be there, and the vascular resistance have to be low, and the dP by dt has to be high. That is, the ventricle should generate pressure fast, the stroke volume should be large so that the pulse rises to a higher level, and it should fall to a lower level because of the low systemic vascular resistance. So these are the hemodynamic indicators. Now we come to that. The low stroke volume, high SVR, this low volume pulse, hypovolemia, cardiac failure, stenotic lesions, severe PAH, MR, ventricular septal effect, where the stroke volume goes to the left atrium or to the right ventricle, so that the forward stroke volume is less. Epstein's anomaly, obviously the cardiac output is low. High stroke volume, this high volume bounding pulse, it indicates hyperdynamic circulation or aortic runoff. Okay, that is the physiology. Now coming to the characters, abnormality, collapsing pulse, whatever term you use, water hammer or Corrigan's or whatever it is, high volume collapsing pulse. What are the requirements? A rapid upstroke, because the ventricle, because of the large volume of fluid, by Starling's law, increases the force of contraction. dP by dt will be very high. So it rises very fast. Ill-sustained peak, because as soon as the blood is coming to the aorta, it runs off to the periphery fast. So it doesn't remain. So the peak is ill-sustained. There is a rapid downstroke because the blood is flowing off the aorta to the periphery in systole. It is not in diastole. Many times people make a statement that this downstroke is because of a diastolic runoff. No, it is not due to diastolic runoff. It is because of the low systemic vascular resistance. Whatever blood is coming to the aorta, it is running off to the periphery. The aorta is distending and the dP by dt is large. The kinetic energy is great. That is stored as potential energy in the aortic wall, a large kind of potential energy which is released. So pushes the blood to a low systemic vascular resistance so that the blood runs off from the aorta. In the lateral part of systole, there is a rapid downstroke and a low diacritic noise. These are the components of a high volume collapsing pulse. So it indicates a high stroke volume, low SVR, and high dP by dP, which has generated a high kinetic energy, which is stored as a potential energy of high magnitude in the aortic wall, which is released later in diastole so that it runs off fast in diastole also. So this is quite common seen in hyperdynamic circulation because all the factors are there, thyrotoxicose, anemia, all those things, the systemic vascular resistance is low. If the ventricular function is normal, the dP by dt is high. Aortic runoff. Is it to the left ventricle as in AR or truncal revegetation? Aortocameral. Common is RSOV and coronary artery fistula. Arterioarterial, aortic runoff from the artery, PDA, AP window, AP collaterals, BT shunt, or it could be arteriovenous, AV fistula, systemic at various levels. So these are some of the causes for collapsing pulse. Now bisvariance pulse. Here, twice beating pulse in systole. This is a large, this is classically seen in severe AR. So obviously the stroke volume is large. The stroke volume is large, so that rapid upstroke, and it is running off in systole itself fast. But what happens is the peripheral vessel as distended like that. There is a rapid distension, it recoils like that, so that the augmented pressure or the late systolic signal pressure, that is that green signal which I showed, will be exaggerated. So it produces the prominence of the late systolic pressure, resulting in the second peak, which will be lesser than the first peak. That is the classical bisvariant pulse, which is due to a strong reflected wave resulting in the prominent late systolic pressure, which I have showed that, which is augmenting it. But this is augmenting it and it has come out because this has fallen. So actual pulse will be like this. Actual pulse will be here, you get this augmentation like that. But then what has happened is here it is a runoff. That is why it has come down and this is separated. The augmented wave is separated from the early systolic wave. So you find it as two separate things. That is the collapsing pulse. Okay, now we talk about the bifid pulse. The bifid pulse, that means twice beating pulse. The additional wave could be in systole or diastole. In systole, you have the bisvariance pulse, which we have discussed, and the spike and dome pulse of hypertrophic obstructive cardiomyopathy. The difference is the second wave is not due to reflected wave. In HCM, this initial thing is the unobstructed ejection. This is the obstructed ejection. So this is something like an AR, because there is hypercontractile ventricle, no obstruction, the rate of pressure rises. Then what happens is the obstructed phase comes. So this is not due to the reflected wave. So it will be more blunted wave. This is a sharp wave. This is in graphic recording. Okay, there is in diastole you have the diacrotic wave, which is occurring after the diacrotic notch, gets prominent. Gets prominent. There is in toxic fevers, in cardiac tampering, in severe heart failure, in hypolimic shock. In all these things, you can have prominent diacrotic wave on graphic record of the pulse, because in all these conditions, except toxic fevers, the pulse volume will be very low. And it is not easy to appreciate the character of the pulse. So if you have the fortune to record the pulse, which is very quite often done when the patient is quite sick, intra-aortic recording, you will find this thing. And obviously, intra-aortic balloon counter pulsation, this is a 2:1. That is, you find that diastolic augmentation occurs. So that they get, this is unaugmented, that is, this is the augmented. So these are the twice beating pulse or the bifid pulse. Anacrotic pulse, nothing much to discuss. Because of the obstruction, the left ventricle generates a great pressure. Still, it finds to empty the blood to the aorta so that the stroke volume will be low. It takes a longer time for emptying. The peak will be delayed. So, low volumes, low rising pulse. Pulsus parvus. Parvi means small. Tardive means slow. That is characteristic of severe valvular aortic stenosis. No differential diagnosis as far as I am concerned for a tardive pulse. Now, Pulsus paradoxus, it's a little Herculean task for the beginners. Why it is called Pulsus paradoxus is a familiar question. No genuine answer for that. What happens is, normally the pulse volume comes down, the stroke volume comes down during inspiration. Why? During inspiration, the intrathoracic vena cava, superior vena cava, the pressure drops. But the extrathoracic vena cava, the pressure is high. So that what happens is, during inspiration, the right atrial pressure will drop. The extrathoracic vena cava pressure remains the same, so that the veno cava atrial gradient increases. The venous return to the right atrium increases. The volume coming to the right ventricle increases at the expense, because the intracardiac volume cannot change. The RA volume increases, the RV volume increases, the IVS shift to the left, so that left ventricular inflow will come down. That is one. Second, in the lungs, in the left side, both the pulmonary veins and the left atrium are intrathoracic. So the fall in intrathoracic pressure is transmitted both to the pulmonary veins and to the left atrium, so that the pulmonary venous to left atrial gradient doesn't change. Third, during inspiration, the intrathoracic pressure falls. That will invariably be transmitted to the aorta. So aortic pressure progressively, proportionately falls. So normally, the aortic pressure or the arterial pressure drops in inspiration by around 10 millimeters of mercury, up to, by these three mechanisms. Whereas in these conditions, an exaggerated response occurs on the right side. That is, there is restriction to cardiac filling. So that whenever a large volume comes to right heart, the left ventricle cannot accommodate it at all. The IVS goes strongly to the left heart, so that the LV stroke volume comes down, and the systolic pressure and the pulse pressure, stroke volume comes down, so that the systolic pressure and the pulse pressure drops to a greater extent. That is, during inspiration, the systolic pressure, the pulse pressure, stroke volume, the pulse pressure, and the systolic pressure drops to a greater than the normal phenomenon. That is Pulsus paradoxus. Probably because in certain cases, the JVP goes up during inspiration, the blood pressure comes down during inspiration, whereas normally both comes down. That may be one explanation. There are one or two other explanations also. We need not bother about that. We should know the concept. Now, the important is, how will you document this? It is easy if it is a total Pulsus paradoxus, as you get in severe cardiac tamponade. If you are asked what is the condition where you get this, so classically it is cardiac tamponade. It is cardiac, not pericardial tamponade, it is cardiac tamponade. Okay, so classically it is described in cardiac tamponade. And total Pulsus paradoxus, when disappears during inspiration, it is cardiac tamponade. And in cardiac tamponade, the rate also goes up. When the stroke volume comes down, the rate significantly rises. So in classical Pulsus paradoxus, due to a cardiac condition like cardiac tamponade, and probably congestive pericarditis, because it's a chronic entity, during inspiration, the pulse pressure drops, the systolic pressure drops by more than 10 millimeters of mercury, and associated with an increase in the rate at that time. if you record it. Total pulsus paradoxus is a typical feature of cardiac tamponade. Otherwise, you can get it in constrict pericarditis, roughly 1/3 of cases. In COPD, it has nothing to do with the hemodynamics. The pulse pressure doesn't change. The intrathoracic pressure change is greater than normal. So normal it is around 5 to 10, but this will be exaggerated in COPD so that will be transmitted to the aorta so that the pulse pressure doesn't change. The stroke volume doesn't change. But when you record, the pressure as a whole comes down. Okay, you can get it in hypovolemic shock, pulmonary embolism, pregnancy, and obesity. But if you get typical pulsus paradoxus on clinical examination, especially with tachycardia, it is tamponade. Okay. For this, the volume should change in the ventricles. And that doesn't happen when there is severe LV dysfunction. LV volume cannot change. Severe AR, the LV volume is very large. In severe mitral stenosis, the LV volume cannot change because it's already low. In ASD, we know the fixed split, all those things. So in the presence of these things, if they develop tamponade, you may not get this finding. How will you document this? I don't know. I will ask Professor Mohit and his whole team whether his postgraduates know how to record this thing. Okay, how to record this thing. It is by blood pressure recording. What is to do is, it is quiet breathing, not a shallow breathing. It is not hold the breath because this is a dynamic phenomenon. So don't say that I will record the blood pressure on inspiration, I will record the blood pressure during expiration. It is not. All dynamic maneuvers are during fairly good dynamic breathing. So what you have to do is tie the BP cuff, palpate or auscultate. Don't look at his respiration. Ask him to take it. He'll be, if it is cardiac tamponade, he will be breathing like anything. You need not intervene. Don't ask him to hold the breath. It is not possible for him. So what you do is look at that BP cuff, BP blood pressure manometer mercury level. Let us say this is 100 millimeters. 100 millimeters, you get two sounds. Okay, 105 millimeters, you get this sound. Then you will not hear the sound. So tuck, 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 tuck. But pulse is 100 per minute. So you find that regular pulse, that is important. It is not in presence of AF. So you find a regular pulse, but you find that when you record the BP, the Koroko sounds are appearing irregularly. So the point at which the first sound appears is 100 millimeters. And you bring it down, again it is irregular, bring it down, and when it comes to this level of around 80, it will be continuous. That different. That is the level at which you hear a few sounds. That is the highest pressure, and the level at which you get continuous level sound. That difference is the paradox. That is how you record. I'm sure that 99% of the postgraduates have not done this thing. Now, reverse pulsus paradoxus is another thing which is asked for your examination. One, positive pressure ventilation. Obviously, more blood is squeezed from the lungs to the left ventricle, so the stroke volume rises. This is isorhythmic AV dissociation. Isorhythmic AV dissociation is the P wave marches into the QRS, it remains into the QRS, then gradually it comes down. This could be a normal phenomenon. This is because the sinus node has slowed down. The junction is firing at around 60 per minute. The sinus node is at around 55, 58 per minute. So what happens is, during expiration, the sinus rate is slow so that the junction will take up. And during inspiration, the sinus rate goes up, you get sinusrhythm-like pattern. So that is a basic thing. It is normal phenomenon. The sinus node a little slower, but it is responding to all the influences. The junction is firing at its almost same rate. So some fluctuation. So this is, let us say this is junction, this is sinus, almost same rate. In sinus, the sinus comes down a little bit during expiration, so that the junction will be firing. During inspiration, the sinus rate goes up, so it will be firing. And when it is junction, there is no atrial kick. The stroke volume is less. During inspiration, it is sinus, the atrial kick is there, stroke volume will be definitely more. So you'll find relatively low volume pulse during expiration and a relatively high volume pulse during inspiration. Now I may ask at the end to Professor Mohit and all the people, It is described in hypertrophic obstructive cardiomyopathy also. I request them to teach me the explanation for that because I could not find it. Okay. Now, to apparently similar thing. There are no postgraduates to volunteer. You find alternate pulses are weak or alternate pulses are strong. So what is the difference between these two? What is this? This is pulsus bigeminy. This is pulsus alternans. Basically, students make a confusion. Pulsus bigeminy is basically a disorder of cardiac rhythm, whereas pulsus alternans is a disorder of pulse volume. I have seen in many examinations and sessions, they cannot differentiate or they are not able to differentiate this concept or they explain this concept. That is, pulsus bigeminy is an abnormality of the cardiac rhythm. It's an arrhythmia, whereas pulsus alternans is an abnormality of the ventricular function or the volume. So pulsus alternans, you say, only in presence of a regular rhythm, classically sinus rhythm. Okay. Here it is because sinus has a larger volume, an early thing, less diastolic filling, lesser stroke volume. A long diastole before the next beat, so that higher stroke volume. Pulsus alternans, it is sinus rhythm regular, alternate strong and weak pulse. It indicates severe myocardial depression. Severe myocardial depression, especially in presence of aortic stenosis or any other condition where there is severe left ventricular dysfunction of acute nature. This usually occurs in acute situation. In chronic severe heart failure, you may not get the classical findings. It is exaggerated by reducing the venous return. Patient stands up or from lying down, the patient is coming up, or nitroglycerin infusion. If the BP is okay, we do that. What happens is you may get a patient with severe myocardial failure and you have started treatment and you put him on nitroglycerin infusion, this may appear. Then you feel that the patient is worsened, but you know that it was there, it was exaggerated by reducing the venous return with nitroglycerin. Okay, his ventricle is overfilled, and when it reduces, this becomes more apparent. It is usually triggered by an ectopic, and mechanism is the calcium loading and unloading theory. In normal heart, following SVT, you can have short runs of a short run of alternans. Now coming to the JVP, you look at the internal jugular vein because it is straight, no valves, so it is just like a manometer put into the right atrium. Whereas external jugular vein is diagonal, goes through the fascia, has valves. They will ask you how to differentiate between arterial and venous, which is a third year MBBS question, so I don't want to discuss that. That question will be asked, it is a third year MBBS question. So you can see that this is the internal jugular vein. You can see that it is between the two heads of sternomastoid in the beginning, underneath the sternomastoid and anterior to sternomastoid. It is diagonal from the ear lobule to this, whereas the external jugular, you see that it crosses in the opposite direction. So it is like X. X. Is it clear? Okay. This is the external jugular. You can see that it is going in this direction. You can say it crosses the sternocleidomastoid superficially, whereas the internal jugular vein crosses this thing underneath the sternocleidomastoid. So you have the, I'm not trying to correlate with the cardiac cycle because a little oddity is there. So you have the A wave, C wave, X descent, V and Y, all those things will come to that. Following the atrial contraction, you have the A, the upstroke of the AV. The atrium distance, obviously it relaxes, so it produces the descent, which is the initial part of the X. The initial part of the X is a passive thing. A wave has ascending and a descending link. So that is the A and X. So X has no relevance at all. Now, during the onset of systole, the isometric contraction pushes the tricuspid or the AV valve apparatus upward. So that produces the C wave. So C wave is due to isometric contraction. And after that, what happens is during ventricular systole, as the blood is ejected from the ventricles to the great arteries, the tricuspid and mitral valve apparatus, because this is applicable on the left side also, but concentrate now on the right side. the tricuspidal apparatus will come down so that the atrial pressure can drop. Second important thing is during the ejection, especially during the early ejection, both the ventricles empties its volume to the great arteries. So what has happened to the ventricular volume? Has come down. What has come to the cardiac volume? It has come down. The intraperitoneal pressure drops so that the right atrium distance to accept the blood. So the X prime is contributed by the early downward pull or displacement of the tricuspidal apparatus plus the rapid ejection of blood, rapid reduction in the ventricular volumes so that the atrium can accommodate, the atrium can enlarge. So the intraperitoneal space is same. The ventricle has emptied its blood so that the cardiac volume has come down so that the pericardial pressure drops, the atrium distance that contributes to the latter part of the X, which is the so the X prime, which is contributed by the downward movement of the tricuspidal apparatus plus the reduction in the cardiac volume due to rapid ejection. Then what happens is the blood comes and fills the atrium through the latter part of systole to reach to the peak of the VV. So you find that from the CV onset to the peak of V is systolic. Here the isometric contraction, here it fills to the peak. Then the tricuspid valve or the mitral valve opens and the blood rapidly comes down to the ventricle so that the pressure in the atrium drops. There is a Y descent. And this part is similar to the ventricular pressure rising. Then what happens is the atrium continues to fill, the pressure rises. To the end of that, atrium contracts. So what happens in diastole is as the tricuspid opens, the ventricle fills to nearly maximum level. But the blood comes to the right atrium continuously, but it cannot empty to the left ventricle because there is a limit for ventricular filling. So that gradually the atrial pressure rises and towards the end of that atrium contracts. So A wave is due to atrial contraction, the ascending limb. The descending limb or the X is the atrial relaxation, and the C wave is isometric contraction. The X prime is because of the ejection of blood, which results in downward displacement of the tricuspidal apparatus plus reduction in the ventricular volume, allowing the atrium to distend a little bit. Continued atrial filling makes the venous wave to rise to the peak of the VV. Then the tricuspid opens, rapid exit of blood from the right atrium to the ventricle results in the Y descent, and then the atrial filling emptying to the ventricle cannot be significant, but blood continues to come to the right atrium and the pressure slowly rises in the earlier, after this in the diastole atrial contraction. Okay, fine. Now if the JVP is not visible, JVP examination is extremely difficult. You have to spend time. I'm sure that majority of the postgraduates are not doing it and the consultants are not after them. Visible or not visible. If it is not visible, it is technical. You are not good in looking at the JVP. I'm sure Professor Mohit Gupta will see the JVP. If it is not seen, he will put it in the supine or 45-degree position to make it visible to assess the waveform. Okay. Then if it is not visible even in the supine position, it means hypovolemia. Markedly above the ear lobules, severe congestive heart failure, it may not be visible. It is easily visible if it is somewhere in the lower or middle third of the neck, because you can see the upper level as well as the lateral expansion. If it is above the angle of Louis, many times I have seen people missing it, I have missed. Okay, then non-pulsatile JVP due to an obstruction or following Glenn procedure when this superior vena cava is connected to the right atrium, to the pulmonary artery. So it is not, I will not say it is not pulsatile. Certain times it is minimally pulsatile, but for practical purposes, clinically, it is non-pulsatile. So look for the height, the reference points. It could be the sternal angle, or it could be root of the clavicle. As a postgraduate, we follow now root of the clavicle in sitting position. You have to look at the waveform, measure the pressure height. Pressure height is very important to assess the response to treatment. The respiratory variation, now it has come in one of the cardiac failure, this thing, which is the most important thing to assess the response to treatment. BNP is not included. in the clinical judgment. It is only for prognostication. Still, they rely on how much the JVP has fallen, how much the lung signs have come down, how much the patient can walk. It is simple clinical. I think the students and the consultants should go through that, because BNP is not coming in that to assess the clinical response judgment to treatment and assessing discharge. Waveform, respiratory variation, whether it is falling down normally with respiration. Abdominal jugular reflex, that is abnormal when the rise in pressure is more than 3 millimeters on sustained abdominal compression. It is sustained for 15 seconds. And on release, it should fall by more than 4 millimeters. So these are the criteria to say that the abdominal jugular reflex is positive. Don't say it is absent. Abdominal jugular reflex is present. Normally, with adequate hydration, if the volume is normal, with abdominal compression, the JVP should come up. Now, it should come down immediately. Within 15 seconds, the rise should not be more than 33 millimeters. Abdominal jugular reflex absent means there is an obstruction to the vena cava. So that the increased abdominal venous return cannot be transmitted to the to the vena cava. This is the normal respiratory variation. Then we come to the waveform, prominent A wave. For that, there should be atrial depolarization. There is a P wave, the proper time. Then the atrial myocardium should be responsive. A non-responsive atrial paralysis due to multiple things, hyperkalemia, ischemia, chronic fibrosis, you may not get an A wave prominent even if it is abnormal. Then there should be a resistance to atrial emptying. So when the atrium contracts, the blood should leave the ventricle freely. There should not be any resistance. And intraatrial septum has to be intact. Otherwise, it can decompress to the left atrium. These are the 4 criteria to have a prominent A wave, which occurs. This is the, you can see that. How to know whether it is an A wave? That's a question. One, it is a sharp wave. V wave is a slow wave. A wave is a sharp wave. You can see that it's a sharp wave. And timing, it is pre-systolic. How to know whether it is pre-systolic? Some examiners want it as apex. Some examiners want it as carotid pulse. Some examiners want it as S1. So try all these 3 things. So how to know whether it is an A wave? So it's a sharp wave which occurs with the before the pulse, before S1, and before the apex. Okay, palpable. So you are happy. So examiners are of heterogeneous type. The prominent resistance to atrial emptying could be resistance by the ventricle. The ventricle is stiff due to RVH, pulmonary stenosis, pulmonary hypertension, RV myocardial disease. Or there is an obstruction to flow of blood from the right ventricle to the right atrium to the right ventricle, as in stenosis, atresia, Epstein's anomaly, like that. This is debatable. ASD with MS. Some people think that still they can have, but because it is decompressing, may not be there. If you look at the JVP classical, it is not prominent. I'll come to that later. V wave is a systolic filling wave. It is a systolic wave. A wave is a pre-systolic wave. And any wave, the height is determined by the volume as well as the pressure. So any situation where the right atrium is receiving a large volume, or it is getting a higher pressure from another chamber, can have a prominent V wave. Here you can see that it is a slow wave. You can see that in contrast to the other thing where it was very sharp. Okay, the other was a sharp wave. Here you can find that it is a slow wave. Okay, and it occurs with the pulse. It occurs with the pulse. Prominent V wave, large volume of pressure come to right atrium in systole, from the right ventricle as in TR, from the left ventricle as in LVRA shunt or AHD with MR, or a large volume coming from an artery like RSOV, coronary artery fistula, or AV fistula. Large volume is coming to the right atrium. Okay, X and XY descent is very difficult. It is more of theory. Sharp X descent characteristic of cardiac tamponade. The sharp X descent with a shallow Y descent. X descent is absent in atrial fibrillation. But don't say that in JVP in atrial fibrillation there is a single wave. JVP atrial fibrillation has 2 waves. One is the V wave and the second is the C wave with the Y descent. So it will go like this. That is, it rises, C wave, then the X prime followed by the V wave. So many times the postgraduates will tell that In atrial fibrillation, in JP, there is only one wave, that is the V wave. But how many descents? Two descents. There is X prime as well as the Y descent. If there are two descents, there have to be two waves. So in JVP in atrial fibrillation, there are two waves and two descent. That is the C wave, V wave, and X prime and the Y descent. Y descent, I think all of you know, severe TR, constrictive pericarditis, all those things. But the basic difference, this is one thing. In both, A and B are almost equal. So atrial septal effect, A and B are equal because it behaves as a common atria. Constrictive pericarditis, we know. But the basic difference is the descents. Descents are more important. And some question, what is the most impressive thing in a normal JP? It is the X descent. X descent is the most impressive visible thing in a normal JVP. So in constrictive pericarditis, A wave equals V wave. The descents are very sharp. So classical M pattern, here it is an M drawn by an infant or a child. It goes like that, or by our consultants and the postgraduates. Okay. So that is it, I think I have discussed. Now coming to the Cannon wave. Cannon wave is a strong atrial wave which occurs during ventricular systole when the AV valve is closed. Normally atrium contracts, the AV valve is open and the blood flows, so the AV wave is normal. Here what has happened, this is a graph and a pictorial representation of complete heart block. You have the P wave, P wave, P wave, P wave, P wave, and the QRS, and you have the AV dissociation. Here the P followed by QRS, so ACV. Here you have the P alone, so A alone. Here you have the P in the ST segment, so the atrium is contracted during ventricular systole, so you get the C and this thing which looks like a V wave, but it will be very sharp. Normal speed is low. So you'll find that there is a very sharp wave occurring at the timing of systole. There is a Cannon wave, which occurs with every cycle, as in junctional rhythm, SVT, VT with retrograde 1:1 conduction. And if the PR is prolonged, suppose this PR is prolonged, what happens is the next QRS, suppose this PR is prolonged, what happens is this QRS will fall on the next PV, so that it can produce a Cannon wave. First degree block, very prolonged PR interval. It is not easy for you to comprehend. Somebody has to draw that, teach you by drawing. So what happens is the PP has occurred here. The P has occurred here. This P is so much prolonged, PR is so that the QRS for this PV will fall here. And at that time, the next P will happen. That is markedly prolonged PR interval. Ectopics and AV dissociation will have irregular Cannon waves. Now, what is the importance of JVP in rhythm analysis? One, okay, I have 10, I think 5 to 10 minutes more. Now, it is easy. Is the pulse fast or slow? Simple. Is it regular or irregular? Again, simple. Now, when it is fast and irregular, your diagnosis is atrial fibrillation. When it is fast and regular, you look at the JVP. If the JVP shows normal pattern, which is very difficult, it is likely to be sinus. If it shows regular Cannon waves, it is SVT commonly. If it shows irregular Cannon waves, VT. Now you can add a simple thing at bedside, a fast rhythm with normal JVP and regular Cannon waves and S1 constant. It is SVT. Fast pulse, regular, irregular Cannon waves, and varying S1, which is simpler. It is VT. So I take that thing also, auscultation, that is in a fast regular pulse, varying S1, VT. Fast regular pulse, constant S1. If it is more fast regular pulse with irregular Cannon waves, VT. So if you have a fast pulse, regular, but pulse volume is varying, S1 is varying. There's some problem with my net. S1 is varying, it is VT. A slow pulse with irregular Cannon waves is complete heart block. Slow pulse with normal JVP pattern is sinus rhythm. A slow pulse with the regular Cannon waves is slow junction rhythm. So these will constitute majority of the arrhythmias which you see. Now I'll just quickly go through that. I took it as an exercise, but I'll come back if our time permits. This is the quiz. I think we don't have the students because the Professor Mohit said that we'll take it as a discussion or a quiz also. We don't have postgraduates. Am I right?
Yes, sir. Today we don't have.
Okay. But I think I will discuss the JP is grossly elevated. Okay, how many waves you are seeing? Is it regular or irregular? It is irregular. How many waves are seeing? You are seeing only single wave. Is it coming down sharply? It is coming down sharply. Okay, you can see that. One pattern of wave which is low rising, very prominent tricuspid V wave. It is falling down sharply and it is irregular. So gross congestive heart failure with prominent V wave, fairly sharp wide descent, it indicates severe TR, no TS, congestive heart failure, atrial fibrillation. Okay, so these are the informations you get. I think it was for the postgraduates. I think we'll skip that. What is the JVP finding in this? Obviously, this is left ventricle, left atrium, right atrium, and you find that there is tricuspid pressure. So what you find is a prominent wave. Professor Mohit, do you want me to continue that because there is no quiz program? Students are not there.
Yes, sir, you can share a couple of them. Then next one, we can have a revision of this and ask them some queries also.
Then I'll think next time. There are only 4 or 5. Okay.
Okay, sir. Okay.
Fine. I think then we'll stop at this point. And I hope I have made things took a little longer time.
No. It's perfect, sir. It's very well because it's not about, it's not about the causes and all these things which are very well given. It's about the concepts that are going behind the these waves and these physiology, like you very well explained, the presence and the physiology of the pulses, starting from the normal nuances that how you should know and repeatedly at least 20-30 times to draw that particular correlation of the diagram. You drawing the ECG followed by the JVP followed by the pulse followed by the various wave patterns, which cycle, cardiac cycle is occurring where, which event is occurring where. This is very, very important, and this is invariably asked from all the residents in exam, that you have to draw this. Followed by this, you explained all the types of pulses, that how twice beating pulse in the systole, both and the systole and diastole. What are the differences? What are the causes? What is the physiology that is involved? You also very nicely explained the Pulsus paradoxus, how interestingly, the three phenomena, the three different events are acting together to produce that kind of a event in Pulsus paradoxus, and Pulsus paradoxus and complete Pulsus paradoxus. This is like, this generally, I have not used these particular terms, but this is interesting to know that it's typical of a cardiac tamponade. And then coming to JVP, it is very, very important to recognize the waveforms and everything. Sir, I have a question, that there have been recent concepts about the addition of JVPs, that typical line of birds that is going on. And they typically say that you should add 5 centimeter, but now ZCT studies are showing that you should be adding more, probably according to the angle of inclination. Does it really hold true in the clinical sense or in the clinical examination? What do you think?
I think that is well described, because the center of right atrium is variable depending on the shape of the chest. Suppose you have a tall, lean person, from the center of right atrium to the sternal angle, flat chest, obese people, and the MRI studies have shown that. I hope you mean that area. That is the center of right atrium and adding 5 centimeters. Am I right? That is not considered now, because MR studies have shown that it is quite variable. And second thing, it doesn't make much difference whether it is 2 centimeters difference. What we want to know is whether the venous pressure is elevated or not. First question, does he have systemic venous congestion? That is why not putting in 45-degree position, it is cumbersome. So sitting relaxed, if it is visible above the root of the clavicle, you take it as abnormal and measure it. So suppose it is 5 centimeters from the root of clavicle. Tomorrow you find as 3 centimeters or 10 centimeters. What you are looking at is there SVC, systemic venous congestion? First question. Or it's a mild systemic venous congestion, normal, whatever you are saying is pathological or not. You do abdominal compression and see whether it is rising. You have got a value above the root of the clavicle, which cannot change. The clavicle cannot change. Then what you are doing is, you have assessed that this patient has systemic venous congestion. Based on the level, you can say it is mild or gross. But what we want to know is what is the response to treatment. That you can easily assess. Next day, you measure it. And now that criteria, I think it is Heart Failure Clinics Journal. It has come in last month, where it's a beautiful illustration, a chart, where it is given what are the criteria, which are the criteria to be considered to see that the patient has responded to treatment satisfactorily, so that you can plan the discharge. Where BNB is not included. BNB is to assess the long-term prognosis, for which they say that there are so many other factors. Okay, so there they have put the degree of JVP should come to this much level. The pulse rate should come down, the systolic pressure variation, the lung signs, how much it should drop, and the patient can walk. It is a little cumbersome, but simple things are given. So JVP is extremely useful to initially to diagnose whether the patient has systemic venous congestion, apart from the other little complex things about the pattern, all those things. Simple in sitting person, it is not difficult to. So what we have to train the students is examine the patient in sitting position, relax, and look for the JVP. Can they see the JVP marked with a sketch pen that this is the level? Then ask them to do the abdominal compression and see how much it rises, mark that level. Next day or 2 days later, you see whether the patient is responding or worsening. So that's all what is needed. I think we should not teach them too much on 45-degree, all those things. It's not worth, I also feel.
Girish, any questions or comments?
As usual, it was a wonderful lecture, sir. And regarding that, you had asked about reverse pulsus paradoxus in HOCM.
Yeah.
Actually, sir, even I have not come across any explanation for it. But one thing which comes to my mind is maybe during inspiration, when there is more blood flow into the RV, maybe the change in the septum towards the LV might increase the gradient.
So then the pulse volume should come down.
Yeah, but I think yeah. So one explanation, one explanation which they have given is probably they say that what they have found out is that LV pressure is increased, and what they have said is that gradient is actually increasing in expiration, not in inspiration, which is usually what is expected. So that is an observation by one of the team, but I really don't know what is the reason for this.
But the problem with this is always we say that when the ventricle becomes small, the obstruction increases and the murmur accentuates. That is, during inspiration, the LV volume comes down, the rate goes up, the contractility increases, the obstruction increases. So all murmurs increase on squatting and decrease on standing. Increases on expiration and decreases during inspiration, except the murmurs. I think I found it difficult. I could not get anyway. Forget about that. That's why I didn't include that, because if somebody asked me that question, what it happens, I will not be able to answer unless the concept is not unless the concept is clear. I will not put into my teaching purpose.
Sure.
Now, sometimes then the student may say HOCM and the exam will ask you what is the mechanism. Then it will create confusion for the student. So it is better that the student doesn't answer that.
Sir's video is not.
Net is a problem.
Okay.
So I think, sir, that's a great presentation. Besides this, there are certain setters, questions that will be asked you: what is venous corrigans? What is jugular corrigans? What is Lancisi sign? What is giant A waves? What are the causes? How do you say giant A waves when it is more than 4.5 millimeters, 4 to 5 and centimeters when it is jugular corrigans is when it is 6 to 15 centimeters. So all these things are like common exam questions that you should be reading when you are going through the JVP from various textbooks. And then you are also asked about the various signs. What is Frederick's sign? All these things related to particular diseases. constrictive pericarditis, what is X and Y descent, in restrictive versus constrictive, what are the venous patterns. So these are asked once you are clear about the JVP and the normal physiology. The abnormal comes very easily for you to actually make out. So I think this is a great talk to begin our this next series of webinar, and I strongly suggest that you all should go back and read from Abraham's and other clinical textbooks. You should again understand the physiology. You should also must read the cardiac cycle and its correlation in with various ECGs and various other parameters, and try to draw it and listen to this particular talk. And I think this will make your concepts more clear. So any other comments, Girish?
Again, like Dr. Sir told that you should always be looking at your patients. The amount of thing your patient teaches is far in excess of what the class we take and the theory which we read. So every time, you come across a patient of narrow complex tachycardia, wide complex tachycardia, or you start immediately saying, you have seen, you are treating, simultaneously look for your clinical findings also. That is also very important. Looking at the pulse, looking at the JVP. So it is very important. And as clearly mentioned, that heart failure, nothing can be better than JVP and pulse in the at least in the in-hospital phase, when you are following up the patient, whether the patient is improving or it is not improving or deteriorating. So accordingly, you might alter your medications and maybe help the patient in his treatment.
Okay, thank you so much.
Thank you so much, sir.
Thank you. Giving me the opportunity to be an opening batsman for the technical session. Thank
you so much.
Nice
Thank you, dear friends. I again request you that this talk will be available on the channel very soon, within a day or so. You all can join us for the next program, which will be announcing soon. I also request to spread this message across all the new batches of DM and DNB residents that they should be joining our WhatsApp group. You can message us, and I'll be happy to provide you the link so that you can be a part of this program live, as well as you can listen to it later on. I also thank Intas for providing us this platform once again, and thank you Delhi CSI for this great opportunity. Thank you. Goodbye. Have a safe
weekend.
Thank you.